Good morning. Thank you. Whoa, that's loud, huh? How's that? Is that a little better? Great. Thank you. Welcome this morning. Let's begin. We don't have our first hearing is scheduled at 9:45. We're going to start this morning with a general overview presentation from the Department of Health and Human Services. So welcome. But before we do that, Senator Long, would you lead us in the Pledge of Allegiance?
Allegiance to the flag of the United States of America, and to the republic for which it stands, one nation, indivisible, with liberty and justice for all.
Great, thank you. So if the folks from HHS are thawed out and they've got their frostbite taken care of, I welcome you to come up. Is there a way we can turn the volume down on this? I feel like I'm in a rock concert.
You can move back.
All right, how's that? Is that better?
Yeah.
All right.
Good morning.
Good morning.
I was just joking. It's like school. They're all in the back. Nobody wants to sit in the front row.
Either school or church, right? Yeah.
Good morning. I'm Lori Weaver, the Commissioner for Health and Human Services, and we're happy to be able to provide an overview for this group this morning about what's happening at the department. I think the first request sort of came in as a state of the state, if you will, of what's happening at HHS, and that would clearly take more than 45 minutes. So we decided to narrow it down for you. So you have a handout that we will go through. I've been with the department for, actually this year will be 28 years, which is a long time, all in different leadership roles, the last 2 as commissioner. I did have a life before the department and was working in a private nonprofit running children's programs in both Massachusetts and New Hampshire. So in terms of just a perspective that I bring. What we'd like to do in the time that we have, the short time that we have today, is our very first slide on here is the agenda overview. Actually, I believe it's slide 2. So I'm just going to talk very briefly this morning about an overview of the department. We would like to spend our time talking mostly with you about the roadmap and specifically those commitments which relate to the work that we do, and then hopefully be able to have some time for you for questions at the end. So getting right into it, the second page is an overview of our mission, vision, values, and primary responsibilities. The department's a really large organization, as I'm sure that you've noticed. After budget hearings, I can now recite stats that say we're 53% of the general fund budget, which is quite significant. We are 1/4 of all state employees, which is also quite significant. We have about 3,200 authorized positions, but only approximately 2,700 of those are filled. We also have a cap at 3,000, a legislative cap that we cannot fill beyond 3,000 positions, and we've stayed within that. We're broken up into 8 major divisions. So we have 8 of those, 8 divisions, 6 of those are programmatic. That's where you'll find your policy divisions, your DCYF, your behavioral health, your public health, your Medicaid, long-term support services. But we also have 2 divisions that obviously are the administrative operational support on the backside of that, which is our division of finance and procurement, which we couldn't do any of the work without, as well as our quality assurance and quality improvement. As you can imagine, we have a lot of regulations and oversight into the work from the money that we're receiving from the feds to make sure that we're spending, or for wherever we're receiving it, spending it appropriately and that we're getting the results that we had hoped for. Additionally, we have 3 24/7 facilities. We did have 4, but we have 4, we own 4, but we have Hampstead Hospital as a clinical provider, helps us run that now. But we have New Hampshire Hospital, we have the Youth Development Center, and we have Glencliff Home. So those are our 24/7 facilities that we currently have. So what does the department do? Why do we exist? Our long game is pretty much what our vision statement says: optimal health and well-being for everyone. I mean, ultimately, that's what all of the work that we do achieves, that we would have a healthy population in the state, which obviously has great impact on everything that we do in a state. We have responsibilities for protection, prevention. We do the client services delivery, so that's in those 24/7 facilities, but that's also case management that we have. So we have adult protective service workers, we have child protective service workers, JPPOs. So about 50% of our workforce is that what we call direct care that sort of faces out and does case management or is in the institutions. And then the remaining portion of our staff are really on making sure all the back end functions for all of those pieces and some management positions. And we also have regulatory oversight, which is something we talked about a little bit earlier. So we have nursing homes, childcare facilities, food protection, food service and inspection, and also public surveillance, public health surveillance and response for anything that is happening on that front. So it's quite a big mission that we're in charge of. So how do we frame that up, which is pretty much the next slide that I want to cover with you. Is what we have. You may or may not, some people in this room have heard about the HHS roadmap. It may be new for some folks for the first time. This is our framework for how do we do our work. It's our strategic plan. It's the 3 C's. It's focused on culture, community, and customer service. So over a course of time, when I was interim commissioner back in 22, going into 23, worked with our stakeholders, internal and external, and said, hey, what are we going to be doing in 23? What are we going to focus on? And that's when the roadmap was born. Quite successful for us in terms of a framework for interacting with folks, and then we continued on. So this is the roadmap for 24-25. It has short-term goals, midterm goals, and long-term goals as well. And we've developed it internally and externally with stakeholders. So for the work that the department has to do, we partner to say, okay, here's the frame with how we're going to do it. So I'll just take you through these bubbles real quick. The first bubble is the invest in people and culture. So the department has made a commitment to its workforce. So it's not just about filling positions, it's about finding the right people with the right skill sets to get in the job and then stay in the job, right? Retention is really important. So that requires a focus on job satisfaction as well as culture. So if we do look at our turnover rate, back in 22, when I took over as interim commissioner, we had a 22% vacancy. In that 1 year of that roadmap, we brought it down, and currently we're hovering around 14.7%, which in a time like that we've been in, when the market is so competitive, that's significant that we were able to draw people to our work, to our department to do this work. People are mission-driven that do this work. That's great. They're not usually in it for the money, but it is hard to compete, as I'm sure that you're all aware of in this market. So taking care of our people and making sure that they can succeed at the work that they're charged with doing. The bubble on the bottom, promote thriving communities. That is the bulk of our work here in terms of when we think about policy, when we think about programs, and this is really all about the right services to the right people at the right time. There is a chock full in the roadmap, and our roadmap is available on the website, and I can also get copies for you. But pretty much we have a significant amount of goals in the roadmap to be able to address all of these. So we're just going to choose 4 for you today. We are picking Mission Zero, which is really about eliminating emergency department boarding. We are going to talk about healthy mothers and healthy babies. And we're going to talk about successful transitions for individuals after incarceration. Why is that important, and how does that work, and why is that important? And also our system of care for healthy aging. So I'm going to have some of my team talk with you about that. The third bubble up on the left side, improve customer service. Excuse me, the department cannot do its mission, cannot meet its mission, cannot do its work without its partner providers. So we are reliant upon providers in the community to carry out the work for us. We bring in the money, we do an RFP, we put that money out. We don't want to make it difficult for those people to engage with us, for those agencies. So we have made and pledged a commitment to improve some of those bureaucratic paperwork processes and not make it so hard to want to help to stay out. right? Because there's a lot of people that want to help, but then when they see what's entailed, it's sometimes it's too much of an administrative burden for folks. So we've been focusing on that. I've partnered with the Center for Nonprofits about 2 years ago now, with the leadership team there to say, talk to us about the private provider community. How can we be doing better? And that goes both ways, because obviously we need them to be doing things as well. So that's been a successful partnership. But also, this is all about data-driven practices. So really capturing what we're doing, is it working, and how do we keep doing that work? So we'll talk a little bit more about that, and also about accessibility. The department is large. We try to streamline for our folks receiving services that it's not confusing on who to call, but sometimes it is. So we're really working on how to make that easier and more user-friendly for those that need our services, and or any constituents or any of your constituents that may be needing help from the department. So that is our roadmap that we're using this for our budget development. We're using this in our budget sessions as well. So department, what are your priorities? They're all in our roadmap. It'll speak to what we're trying to do, how we're hoping, how we need it funded, how currently is funded, and how we'll need it funded. So you'll see that framework over and over again. And that concludes my portion. I would like to take the time now to be able to, before I turn it over, if there's any questions before I turn it over, to start to go through some of those commitments.
Is there any part?
Yeah, thank you, and thank you for your testimony. Basically, on your vacancy, you dropped it from 22% to 14%. How did you do that?
What's the secret sauce? A concerted effort on a lot of our recruitment tools, thinking out of the box in terms of traditionally, how have we recruited? It is going to, we do have pipelines and relationships with schools and colleges. We do have some student loan repayment programs known as SLRP, different incentives. We've done signing bonuses for some of our institutional care, which is a little bit harder to recruit for. We were able to get some tools that the private sector has for recruitment that the state doesn't have, and that was bought at a state level. That wasn't just an HHS. That was an investment by the state that all state agencies benefited from.
Are salaries included in that?
Yeah, well, the salaries, we had the 12% increase that happened in the last biennium. So that definitely, that helped us mostly on retention. So we did see a little bit of a difference on recruitment, but folks that were thinking about maybe leaving and were sort of at that point where they could retire, many of them have stayed. And for us, that's key, because we need to transfer that knowledge to the next line of folks coming in, so that we can keep that going.
May I have one more?
Yeah,
Yeah, and do you foresee going down to like 10 or 8%? What's the goal? Obviously 0, but.
Yeah, I think attrition is constant, right? So it'll hard to be at 0 for a department our size. You always have people coming and going, right? So it's the rate of attrition and how fast you fill after they leave. I would love it if I had all of my positions filled, not realistic, but hovering around 10% is probably the norm that we would see, where the department could carry out its mission and not be hamstringed or difficult to do that. At 22%, it was really hard to do that. And it does have an impact on the people that we serve if we don't have the staff.
Thank you.
Senator Long.
Thank you, Mr. Chair. You mentioned 53% of your budget. Is that all general fund, or does that include federal pass-throughs?
No, that's the federal fund. So we're 53% of the general funds of the state funds, yes.
Okay.
We have multiple funding sources, and we have dozens and dozens of federal funds as well.
Very good. Thank you.
Thank you.
I think that's it.
Great.
Thank you.
Thank you. I'm going to turn it over to Katia Fox now, who's going to talk about Mission Zero.
So good morning. I'm Katia Fox. I'm the Director of the Division for Behavioral Health, and thank you for having us this morning. I really appreciate the time to lay the groundwork for some of the areas that you're going to be hearing about in the upcoming session. So I'm here to talk about Mission Zero. It's a very simple what appears to be a slogan, but what it is to us is a laser focus on achieving 0 individuals waiting in emergency departments around the state for inpatient psychiatric care. And what we have done, it's about a year old, just over a year old. And you'll see on the slide, on page 5, on the right-hand side, we have the strategies. But those aren't the only things that contribute to achieving Mission 0. So what is the issue? This has been a longstanding issue in the state of New Hampshire for probably a dozen years, where we haven't had the right care at the right time available for individuals. And so you'll see it says the front door issue. This is really that boarding that happens in our emergency departments. And that's because there isn't an available bed in a designated receiving facility, the biggest of which you know as New Hampshire Hospital, but we also have DRFs across the state as well. And so that demand has resulted in that wait while we free up a bed and while someone stabilizes from a DRF in able to transition back to the community. And that has caused us to say, okay, we need more beds. So a huge full court press for inpatient bed availability. Well, that's just one piece, because what do you do when someone needs to transition? They're all set, they're steady, their psychiatric acute situation has resolved with their treatment at the DRF, but they need someplace to go. And it isn't just go back home necessarily, and it could be a variety of needs, including supportive housing and independent apartment, a whole bunch of different things that they may need as they transition. And I think as we talk this morning, we're talking about transitions when we talk about healthy moms and babies, and we talk about incarcerated individuals. We're talking about transitions. And so this whole project is designed to, again, to get to Mission 0, 0 people waiting, which we've achieved twice through the course of the work on this, and our wait times for those DRF beds have gone down considerably. But we still need to really focus. We've done a good job on focusing on treatment, on focusing on getting those services and those treatment services in place, but it's those transitions where we don't want to let our guard down, and to really help people move from a situation where they need continued support, but not at the highest level. So the strategies, we have certified community behavioral health clinics. Those are community mental health centers that have integrated care, including substance use treatment. And we have 2 that have, as of January 1st, they're live. And that includes Manchester and Nashua. Those community mental health centers have taken the leap and are providing that integrated care, and it's under a different payment methodology. And if you want a good lecture on payment methodologies, Henry Littman is behind me, and he can, as our Medicaid director, explain that. We also have West Central Behavioral Health, which is provisionally, it submitted its application also to become certified, and the certification is done by the state. We have community-based crisis stabilization. So as you may know, we have mobile crisis services throughout the state that we implemented a couple of years ago. That's great. You have someone to call, someone to respond, but where do you go? And where do you go that you don't necessarily have to end up in an emergency department? You could have a community-based intervention that allows you that time to be able to look in have help coordinating your next stay. So that is a stabilization center, which essentially is an emergency department for psychiatric care that doesn't rise to the need for an inpatient stay. And we have locations right now in Laconia and in Derry. Laconia Mental Health, Lakes Region Mental Health has just opened their center in Plymouth. And then we have a Center for Life Management in Derry. Care traffic control, that is a coordination effort that is headed up by New Hampshire Hospital, and that coordinates and provides oversight for all of the adult referrals submitted for inpatient mental health stays. And so they're able to ensure timely access by having those submissions and being able to look at what's available across the state from a designated receiving facility standpoint. So it's really working together very closely with our hospital-based DRFs and with all of our emergency departments and New Hampshire Hospital coordinating those efforts so that people can get into the care that they need as quickly as possible. We have expansion of designated receiving facility beds. That still is a need. And we have Dartmouth, which is opening up 5 beds later this, what month are we in? Within the next month or so. And as you may know, with HCA acquiring CMC, they're required to add 10 DRF beds to their pool of existing DRF beds. They're going to be adding 10. We have expansions in care, what we call step up, step down beds. Step down is really, again, that backdoor issue that's referenced here. And this is looking at our transitional housing and what's available to help people achieve that independence through the housing and into the community. And then lastly is landlord incentives. Those have been extremely helpful. As individuals from New Hampshire Hospital seek housing, we have partnered with Granite United Way, which helps individuals and landlords match up. And they provide the case management to help someone know how to be a good tenant, and to also provide some incentives for renting to individuals who are coming out of New Hampshire Hospital. As one of our social workers says, you call up and say, hey, I'm from New Hampshire Hospital. I'm looking for a rental for my patient. It's not likely as well received as, hi, I'm from Granite United Way. I'm with this program, and I want to tell you about what the benefits are to renting to someone who's transitioning from New Hampshire Hospital. And that includes, the typical rent and such, but also the backstop that if there's any break in the service, if someone needs to go back and get readmitted, that apartment is held, and also for any damage that may be done that could provide payments and keep that landlord whole. So it's been a great partnership, and we've had great community response for that, and we'll be talking more about it as we get into the budget session. And with that, I'll conclude my portion.
Just want to make sure I'm understanding. You said Dartmouth is opening up 5 beds, and HCA with the CMC, that's 10 beds. And those are for crisis mental health?
Yes,
Okay.
yes, those are going to meet that criteria of a designated receiving facility for those involuntary admissions.
And that's great. I think that's that's something that we're hearing over and over and over again as we're talking to our constituents. I live in a little different district. My district covers from Rumney to Pittsburgh. Are there any plans, or is there a possibility, or can we collaborate to get some of those resources north of the Notch?
We would love to. We have had off and on conversations with our hospitals and with other community providers north of Franklin, and Lebanon's going to be north of that. But we have yet to land on that. It's always a possibility and something that we would welcome because we know those drives and being away from that far from family and from community is a challenge.
Well, if you need any help, I'm going to tell you, this is an open invitation. Anything
Great.
you need from me to help that happen. Dartmouth Hitchcock, if you've got somebody in Pittsburgh, is a 3-hour drive. And I've
Right.
heard from
Yes.
people who have said, yeah, there was a bed there, but we didn't want to go all the way down there, so we're doing this on our own. So I'm very, very, willing. If I can make any connections or anything you need, let me know on that. It's a big concern of mine personally.
Great, thank you.
Senator Ibar.
Thank you, and hate to be a pest. So on the transitional housing, so what's the time frame? I mean, somebody gets,
Yeah.
because I have something unrelated to mental illness, but I've tried to help people in my district, a couple of people that are homeless, can't get them anything, living in their cars, and I understand we have you want this mission zero, going from one place to another and having that transitional housing. How does that work? How do they get placed immediately, or what is the placement strategy or all that stuff?
Oh, absolutely. So for the transitional housing that's referenced here, it does have that mental health condition attached to it. And you may be familiar with NFI North, which runs the transitional housing on the campus where I'm sorry.
The name?
Oh, NFI North. Yeah. So we have prioritized through contract that they take individuals who are transitioning from New Hampshire Hospital or from a DRF. So we want that transition. So a lot of those slots are taken by people who have been hospitalized or are at extreme risk of being hospitalized for their mental illness. There are other types of transitional housing. We have individuals who've transitioned from Glencliff Home to be into the community where their situation has stabilized enough that they're able to have that supportive housing. And I'm trying to think of other types of transitional housing. We have others here who could talk a little bit about for different populations. And the lengths of stay vary depending on the acuity of the individuals that they're serving. It typically is no more than 2 years.
May I have a follow-up?
Yeah, absolutely.
So is there, and I hate to use this word, but is there a competition between one set of individuals versus another? For instance, if somebody just got divorced and living in her car, she doesn't have a mental illness, where is her placement as opposed to somebody who has a mental illness? Is there a friction or a tension of priority for helping one versus another, or are they equal? How does this work? I'm just trying to get some help for somebody.
Yeah. Well, first of all, if you could make sure that we make connections so that we can help the individual that you're talking about, because that sounds like something that we would want to make sure that all resources are made available, which I'm sure you've probably done, but we can take another stab at it. They're in a housing market as we have right now, although I understand it's easing a little bit, there's always competition. And so there's competing dollars, there's competing restricted dollars of who housing is targeted towards or available to. So I think that tension always exists. And we need to continue to really be dedicated to helping everybody.
Yes, Senator Burson.
Thanks for coming in, Katya. The question I have, and I've had some conversations with Center for Life Management in Derry. I know there's issues with uncompensated care, and it may be Henry that we have to talk to, but and I know that they've asked me, or we're going to try and address it, but has the department done anything to try and address the uncompensated care for them?
Absolutely. Uncompensated care has always been a factor, and it only became even more enhanced in the deep way that the centers have experienced it with the Medicaid unwind, which I think you're familiar with. And so we have taken efforts. We've done everything we can to make sure that people who are eligible for Medicaid are signed up for Medicaid so that the community mental health centers can have that payment. We also know that there have been efforts around commercial insurance because they don't always cover what Medicaid may cover. And we have just really worked almost to center by center on looking at their cost centers and making sure they're capturing what they need to for their costs that are reimbursable. It is a problem. We have people who have needs. We do want them to get treatment, but they may not have coverage or have the ability to self-pay. So I know there are legislative efforts around that. We've done what we can to try to shrink that, but it still remains a challenge. And I know we're going to be talking about it a lot over the next 6 months.
Senator Long.
Thank you, Mr. Chairman. The landlord incentives, could you give me your top two incentives that get the landlords?
Yeah, I think it is the initial sign-on bonus, I guess you would refer to it as, and then the case management services.
Okay, that's great. And NFI North, is that the home buying program? There's a program where homes are bought and people are placed in those homes.
So they do own their own properties, and then they work with us as a partner in helping support those individuals. And so it's just what you would expect for transitional housing. It has all of those components that really make it an ability to stabilize and then get the skills they need to have a job, to keep a budget, to be able to transition to something into the community like an independent apartment. But NFI does own its own properties and then partners with it, with us.
Great, thank you.
Anyone else? No, thank you very much.
Okay, thank you.
Good morning. For the record, Henry Littman, the state's Medicaid director. I'm covering pages 6, 7, and 8, and I know we're getting close to your time for hearing, so I'm going to try to go through this quickly. I've been the Medicaid director for a little over 7 years now. What I wanted to lift up is the healthy mothers and healthy babies. While I'm talking about Medicaid, I also want to lift up the fact that there are synergies, which I think you would want to see happen between public health, Medicaid, behavioral health, on this initiative that are working together, and on the second initiative that I'll talk about, which is the community reentry and the youth reentry. We're even going outside the department and collaborating with the Department of Corrections and with counties. In fact, this morning, my team's driving up to Coas County to meet with folks up there to get a sense of where you are with being able to work on community reentry. So let me back
Brought
up.
their mittens. It's cold up there. Today.
Yes, it sure is. So on the healthy moms, healthy babies, the other part I would lift up here in talking through this is that as much as it's important for us to all work together within the Department of Health and Human Services and with the community, the legislative policy is also very important. And I'm going to try to lift some of that up as I go through this as well. In the reducing maternal death, one thing I learned by collaborating with public health is that while Medicaid births account for about a quarter of the births in the state, the deaths that occur in maternal health, Medicaid accounts for more than 50% of that, which, talks about the need to work on more and early interventions there, which is improving early entry into prenatal care. On the next page, we'll talk a little bit about early entry into both postpartum care and prenatal care. We're seeing advances in the Medicaid program with that. There's a decent trend. In fact, the goal we set for ourselves last year, we've already surpassed that. So when I get to the next page, we'll be looking at the next version of the plan to update that goal to try to do more. Here again, I think the Medicaid program, early entry, we have to have them signed up to Medicaid to begin with. So identifying women who are eligible for Medicaid early to make sure that they get early entry into prenatal care, it helps with the first two items there. The same thing with reducing preterm birth. You know, there's a correlation between adequate and early prenatal care. Increasing postpartum care. The 2023 legislation that made New Hampshire one of the, I'd say, midterm adopters of providing 12 months of coverage. If you look at the primary cause of maternal death, a lot of it, the biggest number one reason are behavioral health related issues. And to try to get your behavioral health issues addressed 60 days postpartum, not realistic. I think the 12 months is really important to moving that along. So, you know, we could do as much as we can, but without the legislative policy, we wouldn't have moved that. And then increasing participation in the WIC program, women getting the nutrition and so forth. Someone who is eligible for Medicaid is automatically eligible for WIC. It's a 100% federal program. It's a good program for people to get into, but also legislatively, you enacted legislation to provide further lactation support, donor breast milk that goes through a process. It's not just people passing it to one another, and also the doula coverage, which we're working on as well. Turning to page 7, I think basically on this page I sort of hit on it that we're trying to reduce. New Hampshire relative to the national average is stronger in this area, but one death is too many, so we're working on what we can do there. We're exceeding our goal on early entry. And then sort of lastly, on slide 8, moving from women and children. And let me add one more thing on children. The other thing that has happened with the children side of things is that 12 months of continuous coverage for children is also now, kids under 18 and under receive 12 months of continuous coverage. Postpartum women receive 12 months of continuous coverage. So those are, I think, important things to make moms healthy and their children. With respect to supporting successful transition into the community for incarcerated individuals, the federal government provided 2 tracks to, right now there has historically been an exclusion from providing Medicaid services other than inpatient care to people who are incarcerated. For people who are incarcerated and sentenced, we now have part of our 1115 waiver, the ability to provide for individuals who are sentenced individuals in a prison or jail up to 45 days prior to release services to support their reentry. The number one reason for recidivism is kind of related to mental health and substance use disorder issues. So I think the concept here is when you're discharging someone from the incarcerated setting is to make sure that they have the providers, the prescriptions all lined up. And that's for people with mental health and substance use disorder. We have that now available to adults. So we're working on implementing that. We're starting with the Department of Corrections and then moving to the counties. We've been meeting with the various counties. After today, we'll have met with 8 of the 10 counties to kind of assess how they approach these issues. When you've seen one county, you've seen one county in terms of things. And so you need to design the program in a way that complements what they're doing, because county jails, as an example, may approach how they manage the health conditions a little bit differently. Also, I said earlier that where we're allowed to spend Medicaid dollars to support those settings is where someone's been sentenced in the counties. There are a lot of people who move through who aren't yet sentenced, and we can't provide services to them with Medicaid dollars. So with adults, we kicked off the implementation January 1st in the Department of Corrections. We're also, federally, all states are required to provide a youth reentry benefit. And that youth reentry benefit is a little bit different than the adult one. It's for any condition. The goal of the program is to provide early screenings, preventative services, and diagnostic services before they leave the incarcerated setting, to get them connected to the providers that they're going to see in the community. And then after they're discharged, to give them 30 days of extra intense case management to make sure that the connections are working so they're getting their needs met. I'll stop there because I know you're on time budget.
Thank you. So actually, I was not going to talk about this, and then I saw your slide, and perhaps this is a question better for Commissioner Weaver, but I'm going to ask it anyway because it brought up something that was illustrated in my community about a year ago. And the issue came up when it was actually a private provider who was contracted with Medicaid came into our community, one of our communities, to provide services for folks that were incarcerated. And I'm not going to get into what they were incarcerated for, but there were specific convictions which were quite shocking. And they were all, and I went to a community hearing on this, and the community hearing came about because this was a group home that was operated by a private operator, contracted with the state, and the local zoning ordinances of this community said a group home had to go through and get a zoning variance with that. And one of the things that was shocking, actually shocking the whole community, that's why I was brought in, is they said because they're a Medicaid provider, and they brought a ruling from the Supreme Court, and the town attorney confirmed that, because they're a Medicaid provider, despite what they're doing, despite the type of practice they have, they are not subject to local zoning regulations, which quite frankly was a shock to me. It was a shock to the community because this was going right in a residential community. And again, I'm sorry, I know this isn't and I just didn't know if you could provide any insight into that. I know it's caused a lot of heartburn in our local communities.
I am not the best person to speak to that, but I think it's more of a technical legal issue. I do have some sense of the issue because I served as a city councilor in Laconia for many years, and we had some of those same types of issues. And I do know that there are laws that protect those situations,
Sure.
Not just because of Medicaid, but be happy to get together with you with the right.
Yeah, absolutely. It may be a question for the commissioner, but you were the unfortunate slide that brought it back to my memory.
Yeah,
But I do want to follow up on it because it has continued to be a concern.
Sure.
Now they've moved from one community, they pulled up stakes and moved to another one of my communities. So I'm getting the same types of calls going on now a year.
Sure, I can work with the commissioner and get you the right resources.
Absolutely. Any other questions for Henry? No? All right.
Thank you.
Morning.
Good morning. Thank you.
I'm Melissa Hardy. I'm the Division Director for Long-Term Supports and Services. And I know we're short on time, but I'd like to give just a brief update on the system of care for healthy aging. That was in HB2 in 2023. So I have one slide that I'll go over some of the highlights that we've accomplished since that legislation passed. And then just talking briefly about some next steps. So we were able to complete the CFI, so the Choices for Independence waiver rate study that was in HB2. We had our internal rate setting unit look at rates as far as comparing it to publicly available data, data that providers provided to the department as far as their costs, and also some benchmark data. And we're able to identify certain services that did not meet the rate parity of other states and other programs. So that's reflected in our department's prioritized need for CFI rate increases. We are also able to implement some very important financial eligibility changes as it relates to Medicaid and access to services. Things like the spousal impoverishment, which before it used to be a condition of eligibility and is no longer a condition of eligibility for CFI services. Income disregard, so we were able to allow individuals to keep more of their own money to spend on things that Medicaid and state services and supports don't cover, which will help them live in the community longer rather than having to pay that money towards the program. Also, we were able to look at the Medicaid look-back period, so it was changed from 5 years to 3 years. Which helps families access Medicaid. We are still able to look at the entire 5 years if there is a trigger in there, an asset transfer or something that would question looking into people's finances a little bit more, but it really helps not only the individuals receiving services, but also the department. Instead of looking at a whole 5 years worth of financial eligibility, we look at 3, and if there's anything that triggers a 5-year look back, we would continue to do that for the next 2 years. We submitted a presumptive eligibility waiver amendment to CMS, which would help individuals who meet certain criteria for services to access those services before they are deemed completely eligible by the department and the program. Again, that helps people get services to help keep them remaining in the community rather than institutionalization, whether that's in a hospital setting and a nursing facility setting. So being able to provide certain services, meals, homemaking to keep them at home rather than hospitalized. So we're waiting for CMS to give us the thumbs up or the thumbs down on that presumptive eligibility. So we're hoping that comes soon and we could get that operationalized. Under personal care, we were able to expand the definition of who can be a personal care provider and who can be compensated for doing that. So prior to this change, people who are legally responsible for an adult or a guardian or a power of attorney were not compensated for the care that they provided, only enrolled providers. So through this system of care for healthy aging, we were able to reimburse more people who are providing kind of that free care we were talking about that, again, helps individuals stay at home. And they were providing that care anyway as a caregiver. So we were happy that we were able to make that change. We're also able to invest in our aging and disability resource centers. You probably know them as service links. They are a brick and mortar in each county in New Hampshire that provides information or referral services to people who are needing support in the community. So it's kind of a one-stop shop in your county to be able to talk to somebody and receive person-centered counseling, help with Medicaid applications. And so we were able to, with the money in HB2, invest in some staffing and enhancements in those servicings or adult, we call them ADRCs, Aging and Disability Resource Centers. Lastly, I want to talk about the IT enhancements. We all know technology is important in a coordinated system of care. With the HB2 funding, we were able to improve the functionality of our system that we use called New Hampshire Easy. Some people say it's not so easy, but we're trying to make it easier for people to apply for services, but also for providers to have more access to see and help the individuals that they serve as far as where they're at in the application process or the redetermination process for Medicaid. So we were able to make some of those changes. Also, part of the system of care for healthy aging is to create a public-facing dashboard to track home and community-based service data but also what services are provided and available for people to access. We have not gotten that far yet, but that is something in our next steps as far as our IT enhancements. So we're hoping to create that online portal for identification of those available services on or before June of this year. So kind of quickly, what's next for System of Care? We're about to publish the System of Care for Healthy Aging Plan, which will lay out the steps and how we're moving forward next in the System of Care for Healthy Aging, which included input from stakeholders and providers, other aging advocacy groups, and also incorporates other plans such as the state aging plan. Part of that is developing outreach materials to expand service awareness, making it easier for individuals to apply for Medicaid, which is another roadmap item under customer service as far as we know it's complicated. We know it's very jargony at times. And when I'm a family member, I just want to know, what do I have to do? What do I have to provide? And who do I have to talk to? So trying to make more family-friendly, individual-friendly informational materials that we can provide not only to people, but to doctors' offices, to other referral sources. And also coordinate with other complementary and ongoing efforts, such as the roadmap, such as the state plan on aging, Age Well New Hampshire, and the New Hampshire Alliance for Healthy Aging. So pulling all of those people together to be a part of the next steps with the System of Care for Healthy Aging. Once our plan comes out, and everyone was a part of that, but we're excited to kind of gather everyone's knowledge and resources to come up with, one clear goal and direction moving forward. So thank you.
Thank you. I just want to say, I think we all take for granted how much you do. And it's a tremendous amount of work that you do. And it covers a wide array touches a lot of lives. So thank you very much.
Thank you.
Quick question.
Yes, Senator DeBar.
So does the public guardian fall under this umbrella? Public guardians?
Yes, they play a role, and they're not specific, as part of the actual plan, but certainly we know the need is out there. And I would say that's more related to our work with adult protection. They work hand in hand with identifying and helping people who may need temporary or permanent guardianship. So certainly they're a piece. And I think on the next page, there's kind of an infographic of a system of care for healthy aging. And I would say that they fit into that supports and services for folks.
Thank you.
Yeah.
Yes, Senator.
Thank you, Mr. Chair. Thank you for taking my question. On slide 10, where it says rent and energy assistant weatherization, is this the program? Because I've had a constituent on a consistent basis and contact me about rental assistance. However, I know she has some money in the bank, not a lot in this day and age. Is there any talk of increasing that limitation so people who in this day and age have a little bit more money in the bank than what we already have, that they can receive some of the rental assistance?
Yeah, and that was part of when we did, I think on the slide before, the resource disregard. So we were able to, allow people to keep some of their own funding, where before you had to spend down to a certain limit. We've pushed that limit up to $7,000. That's income disregard. But also we have contracts with, or a memo of understanding with the Department of Energy to help people with fuel assistance, whether it's oil or wood or weatherization of homes. So I think it's a huge need, but I think that does help a little bit in allowing people to keep some of their own dollars for things like that.
Just, you have it at 7,000. What was it prior?
2,500.
Okay, thank you.
Yes.
Silly question, is this part of the system's benefit charge that people are, I don't want to get into energy, forget it. Does the systems benefit charge get applied to this?
I'm sorry, I cannot hear.
Does the systems benefit charge get in energy applied to this weatherization?
You know, I don't know that. I would have to look into that and get back to you because we don't administer that program, but we provide referrals to the Department of Energy for older adults who require help with, you know, fuel assistance and weatherization. So I can look into that for you.
Thank
Thank you very much.
Great, thank you so much.
All right.
you. Energy.
Yes. Especially a day like today.
Good morning.
Good
Dan
morning.
Landry, Associate Commissioner. I realize that we are way over time, so if you like, I can wrap this up in just a couple seconds. But I just wanted to highlight Commitment 3, which the Commissioner spoke about briefly in her presentation, which Commitment 3 is really about improving customer service for individuals and provider partners. So we have 5 initiatives under this commitment, and they're all about improving our internal processes and systems to really enhance the delivery of services and drive value for our stakeholders, which include all New Hampshire residents and all of our provider partners and our staff and everyone. And so just to highlight, rather than go through all the initiatives, just to highlight what that means in action for us is an example of how we've been touching upon all of these initiatives for the past year, as we've had a partnership with the Center for Nonprofits for the last 12 months, and it's ongoing. And we meet with center leadership as well as with leadership of some of our biggest providers representing the different areas of our services. And really, it's about how can we be better partners? What are the pain points from their perspective from contracting with the department, whether that's the contracting process or the payment methodologies, or how their constituents are able to access our services. And it's all about listening and bidirectional information communication. Some things we're held to by federal law, and we can't change that process for them. But anything that we can make easier for our partners, we're trying to do that in an open dialogue. And at the same time, also trying to provide trainings and resources on what it means to partner with the department and how to better access our contracting techniques or our payment methodologies and have you. So it's really, and I look at it from a business perspective as our operational excellence, if you will. All of these initiatives are focused on the less exciting external facing delivery of service or programmatic work, but it's really that internal operations, driving value, becoming more efficient, more effective, improving our processes to deliver better programs. So I'm happy to answer any questions on that. And also wanted to highlight that John Williams has already emailed Ms. Littman our roadmap to distribute to everyone. So apologies for not having copies of that for everyone.
Great.
Yeah.
Thank you. Any questions? No.
Okay.
Thank you very much.
Thank you on behalf of our department. We appreciate
All
your
right.
time and look
Thanks for
forward to more
coming in. We
discussion.
appreciate it.
Yes, thank you.
All right, with that, we are going to open the hearing on Senate Bill 47. Do we have sign-ins? Okay. Thank you. Good morning, Senator.
Good morning. Thank you for taking my testimony. For the record, my name is Regina Bartzell, State Senator for District 19, which encompasses the towns of Derry, Hampstead, and Windham. And I am the prime sponsor of Senate Bill 47. Excuse me. So this bill I am introducing Senate Bill 47 at the request of the Insurance Department. This bill seeks to insert clarifying language into RSA 415:22 relative to the coverage for newborn children in order to codify how the department has been interpreting the statute. RSA 415:22 was first enacted in 1975 to ensure that when a child is born, that child has insurance coverage from the moment of birth until the first 31 days of life under the parent's insurance policy. Over the years, the Insurance Department has issued bulletins providing guidance on the application of the statute. This proposed bill simply codifies that guidance to ensure the newborn child received the protections as intended when the statute was first initiated. Michelle Heaton of the Insurance Department is here to explain in more detail the proposed changes, and will take any questions. So thank you for your consideration of this legislation.
Thank you. Are there any questions?
Good job.
It's easy. So with that, I'm going to call Michelle Heaton.
Good morning. My name is Michelle Heaton. I'm the Director of Life and Health at the New Hampshire Insurance Department. And I'm here today to talk about Senate Bill 47. As Senator Prentice mentioned, this provision has been around for a long time, since 1975. It is an insurance mandate that requires insurance carriers to provide coverage to newborn children from the moment of birth through the first 31 days of life. And the reason behind that is because you can't buy coverage before the child's born. So it gives that 31-day period to ensure that there's coverage. And then after that 31st day, the child would need essentially their own coverage. So usually they're added as a dependent to the parent's plan, or some other coverage would be purchased depending on the situation. So over the years, the statute is fairly basic and requires that coverage to be part of the plan. But over the years, there have been different scenarios that come up and questions that have come to the insurance department. So we've issued some guidance. So back in 2017, we issued Bulletin 17-001-AB. And then earlier this year, or just this year, we issued another Bulletin 25-002-AB. And both of them are just providing more guidance on how we have always interpreted the statute. But we also thought this would be a good opportunity to codify some of that guidance, because it's legally, it goes a lot further if it's in the statute as opposed to just guidance being issued by the department. So really what we're trying to clarify is that when the birth mother is in the hospital receiving care, they've already paid the cost sharing for that hospital stay. There's no additional cost sharing once the child is born. So you can assess then an additional cost share, copay, or co-insurance, because now the child is also in the hospital. We also are clarifying that when there are services being provided and cost sharing collected for the child outside of, the episode of event of the birth, but some other time in that first 31 days, those cost sharing goes to the parents' accumulators because they're part of that policy for the first 31 days. We're also clarifying that for that first 31 days, there's no additional premium that could be collected because it should already be part of the benefits for the parents' plan. So I'm happy to take any more questions.
Senator.
Thank you for taking my question. I just want to make sure this will help with any confusion with the insurance carriers, and they're on board with this, correct?
I think it helps clarify any conclusions. I'm not going to speak for them, but we did provide the language to carriers back in the fall. We tweaked some of the language based on their feedback, and we haven't received opposition from them, but I'll let them speak for themselves.
Any other questions? Senator Prentice.
Thank you. Good morning, Attorney Heaton. Good to see you. So I'm just trying to remember back 27 years ago when Phoebe was born. And I mean, I had health insurance and I went to the hospital and I had my baby, and somewhere in there, I must have, in that fog, written a note or signed something that got her insurance coverage. I mean, so what I'm just trying to understand is, I mean, I understand partially how we got here, but isn't, I imagine along the way that there's a provision that when these babies are born and you're pregnant, the baby is born, that coverage, like there's like a signal. And are you trying to cover that signal on the track is missing? Or is it consistent across the board? Like,
I mean, it's fairly consistent. If you go back to 1975, insurance landscape looked very different. It's pre-ACA, obviously. So, you would have a maternity benefit rider sometimes on your insurance policy. And the whole point of the statute is that for that first 31 days of life, you don't have to worry about, getting that insurance immediately. You have that 31-day window to then pay premium and get the baby added to a plan so that on the 32nd day, the coverage continues. So for, employer-sponsored plan, which I think most people had during this time, you would just call your employer or your insurance, say, oh, I had a baby, add them to the plan, and then you would pay the additional premium for the new person on the plan. But, I mean, it is fairly seamless, but, there's a lot of nuances that come up in very particular situations that have required us to issue some additional guidance. But for run-of-the-mill cases, it's pretty straightforward.
Yes. Well,
so, in 1975, I was in the 5th grade, so I didn't have. So I think so thank you for that clarification. Do all insurance providers not have the same, like, say, process for managing this first 31 days? And is that why this will help?
Yeah, I think where you get tripped up is with claims administration. So I think it's typically where we see issues, and sometimes we have to clarify some stuff with the carriers, is when the child is born and maybe they're in the NICU or they have some medical problems. So usually when you go in, and I'm speaking very generally, there's a lot of nuances here, but if you're in the hospital, you have a baby, that episode of the birth is usually a bundled service that you're going to get the hospital gets a payment for. When there's other things happening, like the baby's in the NICU or something else happens, that there's additional benefits, sometimes there can be some adjustments that need to be made with the claims processing, and sometimes it's not clear. So that's why we're trying to make more clear how coordination of benefits, collection of premium, all of those things work for the cases that are a little bit out of the run-of-the-mill.
So no parent, sorry, may I Chair?
Yeah, absolutely.
So no parent with coverage will have to worry when they get this, statement that says they owe all of these dollars for, care, like you pointed out, like NICU care, that should be covered, but there wasn't that like automatic trigger that clarified it across all carriers. I'm not going to worry.
Yeah, I would think 99% of the
time.
yeah.
I have to pay, like
99% of the
insurance.
time, I think it's seamless, and parents are not seeing these things. Where it can get tricky is sometimes if parents have different insurance coverages, maybe one of them's Medicaid eligible. There's a lot of nuances that can go in there. So I think that 1%, and it's probably less than 1% of the time, there's specific circumstances that cause some confusion. But I would say 99% of the time, carriers are on top of this. There are no issues.
Thank you.
Senator Long.
Thank you, Mr. Chairman. Thank you. So line 7, I just need a clarification, line 7 through 11. So in the case of a divorce, one of the parents is responsible for insurance, the other, let's say the mother in this case has insurance, but it's not covering the bundle of the birth the father is. So in this case, the 31 days will be covered by the fathers who's paying.
So I would say pretty much all insurance, I don't know about self-funded plans, but I would say most of them, it'd be hard pressed to find it, have to cover maternity services. So if the mom has coverage either under a self-funded plan
or a health plan, the newborn is going to be covered under hers because she's already receiving treatment along with it. So she would already be paying the cost sharing. And we don't want to get in the situation where you're paying once for mom and then paying a cost sharing again for the baby for the same services, essentially. Where this would come in would be if for some reason mom has, say, self-funded insurance and for some reason it doesn't cover the newborn care, because this mandate is for the insurance market, not for self-funded. I think it's a general practice that it is covered, but say there's some weird quirk that it's not covered, but dad has coverage that's commercial insurance, then dad's plan in that case would cover it. But say if it's a divorce and the divorce says that dad has to pay for the children's health coverage, then dad would pay for that plan on day 32. But as you can see, there's a lot of nuances, weird situations, different factors that come into play. So sometimes depending on the situation, this can get very complicated and tricky. So that's why we're trying to put in the clarifying language to help people out.
Okay, follow up if I may?
Yes.
Thank you. So what if there is an issue with the child at birth? So 31 days, the premiums don't go up, can't go up. So it's a 32nd day when the insurance would possibly
That's when,
premium if there was an issue with the child.
yeah, so on the 32nd day is when the child needs to be on one of the parents' plans or have their own plan. And that's when they would collect a premium for that plan. Now, if the child has health issues, you cannot consider that in as a factor in determining appropriate premium. So that's not really an issue anymore.
Very good. Thank you.
I've got something just real quickly, and I think you've probably answered this, but I want to make sure I'm clear on this. Baby's born under mom's insurance, covered under mom's plan. And I think you answered it in that usually during that time with an infant or a newborn, it's part of a package payment. Would you foresee any instances, and again, I'm asking you to, this is a what if question, but would you foresee any instances where baby's covered under mom's plan, the baby needs a procedure or a service or whatever, and the insurance said that's not covered, or that requires a prior authorization, or so technically they're covered, but they're not paying for that specific service. Is that something that you would foresee as a problem or a potential problem? Because the words say, the child should only be covered under the policy of the other parent. I mean, because technically they've got insurance, but I think a lot of us have had insurance and something's not covered.
So I think for the most part, everything is going to be covered.
Okay.
So I wouldn't worry so much about that. If there was something experimental that maybe the child needed and maybe the plan's not covering it for some reason, it does say that mother's plan should always be primary. So there is still the ability, if for some reason, some crazy scenario where mom's plan is saying this is not a covered benefit, but the other parent's plan says it is, there would be opportunity to go under the other plan.
Okay.
But for the most
So
part,
you're
all of,
comfortable that the baby would be cared for?
yes.
Okay.
Yeah.
All right. That was my question.
This is, these would be services that are part of the essential health benefits that are going to be covered unless it was something that's not medically necessary, then insurance wouldn't cover it and it wouldn't matter which plan was the primary.
Great. Thank you very much. Brianna Henkel? All right.
My name is Brianna Hinkle. I'm the Legal Policy Fellow at New Futures. New Futures is a nonprofit, nonpartisan organization that solves New Hampshire's problems through policy change. New Futures supports SB 47 because it helps clarify the current statute, which reduces burdens on families and provides coverage for infants for the first 31st day. Infants right after birth begin receiving treatment and screenings, which is critical for their future health and can impact their futures as well for lifelong implications. Thank you.
Great. Any questions? All right. Thank you for coming in today.
Thanks.
Okay, Paula Rogers. Good morning.
I was not going to speak because I spoke with the chairman actually in the hallway and indicated that insurers have been basically accommodating this provision in law for some time. And it was, obviously, there were issues that the department heard that there was enough initiative there to figure out whether there was a way to make it clearer and work better, quite frankly, for mothers and newborns. And I'm representing AHIP, which is an association of health plans, and it's interesting how sitting here not expecting to speak, suddenly you get all sorts of communications that come in. And so I'm entirely unclear as to whether we have a unified concern or not. I suspect it's not a concern substantively, but there are some issues with the way it's drafted where I'm reading it to make sure that we understand. So as I understand the bill, the department, Michelle Eaton, indicated that they felt there was a need to clarify. I think it's a bulletin from 2017, and they've done that with their own bulletin. And I think what they're getting at is that when mom is insured and goes to the hospital and has a baby, for routine care of that infant during the first 31 days, that's under the mother's policy. No additional cost shares. That is not considered a dependent, that child. It's just subsumed within her coverage, the mother, in the contract. And I think that's all fair because there are lots of things going around with childbirth and people sort of forget, they may know where they're insured. There may be another insurer out there. When I picked up the draft and looked at the bulletin, I wondered what happens when you have two insurance policies and something non-routine occurs with that infant during the first 31 days, something that requires specialists, maybe some newborn care that you wouldn't have in a typical newborn situation. And is that covered on, because of this change, is that only covered under the mother's policy? And how does coordination of benefit work with a policy held by a dad, for example? And so I think there may be some need for the carriers to actually talk with the department a bit about this. It has nothing to do with the substance, really. It's just a matter of understanding what this change would do. And it just needs to be clarified, I think. And maybe the department can reassure us that they figured out what happens with the coordination of benefits. Because coordination of benefits is it's in rulemaking, and it's a very arcane thing when you have different policies with kind of different coverages, and you're trying to coordinate between carriers who pays for what. And the way this reads, it sounds like the birthday rule, which used to apply, which is at some point, on non-routine infant situation, as I just described, at some point, there would be the discussion of whose parent is the earliest in the calendar year. I mean, that's how complicated it gets. So just sort of sorting that out with the department, having some time to do that, I think would be helpful. But again, I want to assure you there was no concern about the substance of what the department's trying to do. And one other thing is just the effective date on the bill. If generally on compliance things for carriers, the effective dates move to January 1st, and this one I think is 60 days. So I'd be happy to try and answer questions, but I know I could see that people had questions, and I'm no expert on coordination of benefits, and unfortunately I did not talk to Michelle before the hearing, and maybe I could have worked that out.
Yes, Senator Bertzel.
So, thank you for taking my question. So didn't I hear the insurance company or the insurance department say that they sent the language out to the insurance companies?
They did send
And they
it.
made some tweaks for it?
That is entirely true. I did not talk to the department about this. And I only heard issues this morning on the effective date. And for that, I'm sorry, Senator, if I knew the department had a cluster of bills that were provided for what they were going to introduce legislatively.
Any other questions? Thank you very much.
Thank you.
So we're going to move on to the next. So I'm going to close the hearing on Senate Bill 47. Okay. Is there anyone else that would like to speak on Senate Bill 47? All right, seeing nothing, I'm going to close the hearing on Senate Bill 47. Thank you. All right, we're going to open the hearing on Senate Bill 36. Senator Abar.
Thank you, Mr. Chairman and committee members. For the record, I'm Senator Kevin Avard, District 12, and I am the prime sponsor of SB 36. I think we've seen something like this in the past, but I'm reintroducing it, giving it another shot. I've introduced SB 36 so that New Hampshire can finally join the 46 other states that collect anonymous abortion statistics. States that already collect and report these statistics, including Massachusetts, Vermont, Maine, New York, Connecticut, Oregon, Washington State, Illinois, and there's also collected by governments like Washington, D.C., and of course, New York City. And according to the CDC, New Hampshire has continued to refuse to collect these anonymous statistics, put us in a group of only 4 states in America together with California, Maryland, and New Jersey. Each year, the CDC publishes a nationwide report on abortions, and each year they include a note that these 4 states, including New Hampshire, are a dark area because we alone refuse, for some reason, to collect any anonymous statistics on abortion in our state. Gathering accurate abortion statistics in New Hampshire is necessary because major abortion providers have repeatedly and publicly misrepresented the practice of abortion in the state. And I'll give you 2 examples. You may remember that in 2021, there was a lot of debate about our current prohibition on abortion of 6 months old, viable children. In mid-June of that year, abortion providers, including Lovering Health Center, argued that the law's ultrasound requirement was unnecessary because ultrasounds are already routinely performed before most abortions in New Hampshire. On June 22nd of 2021, New Hampshire Public Radio reported that, quote, medical providers that perform abortions in this state say that ultrasounds are already routine for the most abortions. Only a week later, however, abortion providers around the state had changed their story. Suddenly, they were claiming that the pre-abortion ultrasounds are extremely rare and unusual. On June 29th, Equality Health Center and other abortion providers told the union leader that pre-abortion ultrasounds are almost never done in New Hampshire, and that requiring ultrasounds to determine gestational age would radically transform the practice of abortion. This began a period of several months in which Planned Parenthood and other providers portrayed the routine obstetric ultrasound as a rare and bizarre procedure in which women would be probed with the strange devices. And by January, one state representative even described the obstetric ultrasound as rape. This all happened with no real scrutiny or pushback from the New Hampshire media. One of these two stories must have been false. Abortion providers were either misrepresenting their practice in mid-June of 2021 when they portrayed obstetric ultrasounds as a common, or else they were misrepresenting them in late June when they said it was unheard of and barbaric. The same thing happened on a question of how many abortions are performed at each stage of pregnancy. Over at least a few years, many abortion providers have criticized the 6-month law, which has an exception for a mother's health, by arguing that women need late-term elective abortions. But back when similar bills came up in the House in 2016 and 18, abortion providers testified that late-term abortions simply do not happen in New Hampshire. Once again, only one of these stories can be true. People of both parties have an interest in this issue. A poll this year by Data Orbital found that a large majority of Granite Staters are opposed to late-term abortions or abortions after 15 weeks. There is no risk to the mother's health. This included 62% of undeclared voters and 43% of registered Democrats. Around 60,000 abortions happen after 15 weeks in the US, which means that hundreds of late-term abortions, elective abortions, are likely happening here in New Hampshire. The people of New Hampshire deserve to have access to this information so that we can make informed policy decisions throughout this democratic process. SB 36 means that abortion providers will no longer be allowed to create whatever picture they want to suit their own purposes at that moment. We will finally shed some light on this industry and set a record straight on what methods are being used to perform abortions, how often they are performed, and at what gestational ages. At the same time, we will remain firmly committed to the privacy and keeping all patient information strictly anonymous. This bill will gather information of the practices of abortion providers, but it will gather no information on the identities or the sensitivity of information of women who receive abortions. Finally, I ask that this bill be not enacted by the committee until we reach an amendment. I've got a couple of fixes that I have to do. I introduced this bill basically as a placeholder, but I'll need to include basically penalties for violation in order that this bill will work. I look forward to working with the committee on the amendment, and I'm happy to take any questions. Thank you.
Any questions of the committee? Senator
We have to work on these microphones.
Question. Okay.
For those of us that might be challenged. Senator Avard, thank you for taking my question. I have a number of them, but I understand from you that this is not the final version. But, you know, one and I want to hear some other testimony I want to ask about is in section 2, item F, any prescriptions written for the purpose of inducing abortions? Why are we gathering that? Are we going to make a distinction between, is it?
Why any prescriptions written for this
Yeah,
purpose
I mean,
are included?
Yeah.
I couldn't answer that just yet.
Okay. No, so that's just one that I want to talk to you about, and we can, you know, again, I understand that this is not your final version. Senator, Chair, can I
Absolutely.
follow up?
Yes.
So, you know, one of the things I think that works well for New Hampshire, what sometimes is problematic is we hold privacy standards in terms of our data to very, you know, the high water mark is up there. But there are times in other areas of healthcare where we've had conflicts over what is shared and what is not shared. So, you know, when you name the 4 states, part of me is like, we are very protective of our data, and that's great. But there, you know, I just want to point that out. I had no indication that New Hampshire refused to provide any data. So I'm interested in hearing more about that. But one of the things I want to put out in this, all of the different, pieces of information that are being requested is that if we are going to, and you stress this, which I appreciate, continue to have, protect the privacy of these patients, we have to make sure that we do not collect data in a way where a town or a city or a location could be revealed. There is out there, and somebody, maybe someone from Health and Human Services can help me with this, but there's a standard. If there's only so many incidences of, say, a heart attack in a certain zip code, that if it's under, say, 5, it's not reportable, because it could in a small town. If, someone has had a heart attack, everybody might know who that person is if it's reported. And I just want to translate that over into the protections here, that we're careful about how we record the different, the different locations, so that we are not, that we're not violating privacy on that level too. I mean, there's a lot. So I do want to talk about prescriptions. I do want to talk about locations, and then state and.
Absolutely.
Oh my God.
All right.
Thank you, Senator Avard. State of residence, Section 2, Item C. Why do we want to know about the state of residence? Are we talking about New Hampshire patients?
I think this is a very important question. There are 340,000 children that are unaccounted for in America that have been either come across our borders or being used as sex slaves. And we want to make sure that no child is coming across our border being used in our facilities for an abortion and then taken back across state lines. We want to know that this person is of a particular age and they are state residents. But we have an issue in our country where there are children that are being sex trafficked, and we want to make sure that we can put a lid on that. We want to stop that. And if these places are being used as a place for children 16, 17 years old as sex trafficked, we want to make sure that information is captured. We need to keep this information. And I think that's a very important part of this bill. So where they come from, it's important. Follow-up.
Thank you for that clarification, Senator Avard. So what I hear what you're saying, okay? And but what I do want to make sure of is that women who legally come here and, and legally obtain abortion-related services are not being, that there's no overreach from another state in here because this data is available. I don't want a monitoring or overreach provision. I hear what you're saying, okay? So I think that there has to be a separation of the two.
Yeah,
Okay, but it could be, as I'm seeing this now, and I know you have more work to do.
Yeah. Thank you.
Thank you.
Appreciate the question.
Thank you. Any other questions? Senator Long.
Thank you, Mr. Chairman. Thank you, Senator.
Yes, sir.
On item 3, I see the effective date is upon passage. So if this were to pass, signed by the governor sometime in July, you would have 5 months to have a report. Do you think that's
I can look at that.
That's
If
enough
you
time.
need to extend it, we're
okay? And also the medical facility shall report the information disclosed pursuant to paragraph 2, at least annually, or as required by the commissioner. So the commissioner can determine, I want these quarterly.
Repeat that again? I'm sorry.
On line 15,
Yeah,
it says disclosed pursuant to paragraph 2, at least annually,
right.
or as required by the commissioner. So the Commissioner of Department of Health and Human Services could say, I want these reports quarterly instead of annually.
I would think if they suspect some malfeasance, maybe that would be okay.
Okay.
But at least annually, you know.
Okay. And that line only refers to the report, not number two, what they will provide, correct?
I think so, yeah.
Okay, great, thank you.
Yes, sir.
Further questions? Senator Prentice?
Just for clarification, Chair and Senator Avard, so we're going to be hearing from Health and Human Services.
Yes.
I saw Associate Commissioner Tilly has a statement in here.
Yes.
Okay.
Yep.
No, all right, great, thank you.
But I'm not gonna call her yet. I'm actually gonna recess the hearing to, what's that? Briefly, yes, just procedurally. And I'll take a motion.
I'll second that.
Second that. So we're in executive session.
Can I
and-
come over there?
Yeah, you can come on over. Come on over. You're not off the hook. We're not gonna exec the bill. Yes. All right. We're not executing the bill. Senator Prentice has a motion that we're in executive session. Just got a motion.
I've got a motion to request that the LBA provide a fiscal note on Senate Bill 36.
Second.
So the motion is to get a fiscal note for Senate Bill 36. Any further discussion?
Just,
Yeah.
we might want to add on to that motion pursuant to RSA 1446, looks like VA.
All right, you got that?
Not V8, but VA. Okay.
Any discussion on that? All those in favor say aye.
Aye.
So I would take a motion to come out of executive session.
Second.
Right. So we're gonna come out of recess. So we're back in the hearing. So we're gonna call Patricia Tilley. Actually, I'm sorry. I'm gonna have you sit down for a minute. I missed this here. I missed two. I wasn't looking down my list. Representative Gould.
And I'm Representative Linda Gould from District 2 in Bedford, New Hampshire. And I support this bill. And basically, all I'm saying is that there's no reason not to have statistics. And I have some handouts for you I will give over here for you to have, including the magazine that is all about statistics. And so basically, I'm just saying that there's no reason not to have statistics. And I do support this bill. Do you have any questions?
Are there any questions of the committee? Thank you very much.
Okay.
Representative Nodder.
Thank you. And good morning, Senators. Nice to see you. I'm Janine Nodder. I represent Hillsborough 12, the town of Merrimack. This is a bill that I have prime sponsored before in the past. There was a couple of things that were brought up earlier. So if it's a small town, like I have a friend that lives in Perryville, Arkansas, everybody knows everybody's business. It doesn't matter what's reported. However, for statistics, if it's aggregated, I believe that's the right word, by county, people are protected. So it's not going to be a worry. I just dug out of my files some previous testimony, and this is from Denise Burke, ESQ, who was the Vice President of Legal Affairs for Americans United for Life. It's short. In today's culture, abortion has been marketed to women as a cure-all solution to an unintended pregnancy. Masked by inaccurate and incomplete data on abortion safety, the true dangers of the abortion procedure are ignored. How many women have been injured or have died from botched abortions? How many women continue to suffer in silence from long-term abortion complications? How many abortions are actually performed in New Hampshire each year? We simply do not know. As the author of a leading abortion textbook acknowledges, There are few surgical procedures given so little attention and is so underrated in its potential hazard as abortion. In order to protect the health and lives of women, complete and reliable data on abortion must be available to women, the medical community, and the general public. A comprehensive state reporting system, one that emphasizes reporting on complications, is the only way to accomplish this goal. Only when such a system is in place will we finally be able to unmask the reality of abortion in New Hampshire. Thank you.
Thank you. Any questions? Thank you very much.
Thank you.
Okay, Patricia Tilley, now we're all set. Thank you. Okay. Thank you.
Good morning. Thank you for taking my testimony today. My name is Patricia Tilley. This is very loud. I'm going to move it a little bit. My name is Patricia Tilley. I'm an associate commissioner at the Department of Health and Human Services. I am pinch hitting for our public health team today to talk a little bit about Senate Bill 36. So our understanding is Senate Bill 36 intends to redefine the reporting requirements that exist within the Fetal Life Protection Act, which is in RSA 329, 44 through 49. The department's interpretation of this bill is that it requires the development of a new data reporting system for all terminated pregnancies and ongoing analysis of that data. Just for informational purposes, it's a little hard to follow in the RSA sometimes. RSA 329 sits within the authority of the Office of Professional Licensure and Certification. It sits within the medical code within there. It doesn't actually sit within the Department of Health and Human Services. However, it does direct the Department of Health and Human Services to collect this data. So just as you're trying to find it in the statute, that's how it sits. It also appears that there may be a technical error in 36 as drafted. It refers to RSA 32949 as reporting, but in my understanding and quick look of it, the reporting section is actually 32945. Again, I'm not a lawyer. I don't play one on TV, but folks can figure that out when it comes time as you work on the bill. So in 32944, it currently states that except in the case of fetal abnormalities incompatible with life or a medical emergency, no healthcare provider shall knowingly perform or induce or attempt to perform an abortion upon a pregnant woman when the probable gestational age has been determined to be at least 24 weeks. That is legislation that I know that policymakers have worked hard on and has gone back and forth, but it does provide for the health of the mother in that statute now. So just for clarity. It then in the reporting section basically then says the department is to receive any reports of abortion that occur in that time period, the 24-week. We have not yet received a report to that case. So just again, for any understanding of where we are around reporting today. As Senator Avard capably described, New Hampshire is one of only a handful of states, as you noted, a handful of states to not mandate the collection about abortion data. That is because we don't have the authority to collect that data, which is why. So there is not a sense that we refuse. It's simply as policy, we don't have, the Department of Health and Human Services does not have that authority to request that data at this time. As drafted, Senate Bill 36 seeks to replace these previous reporting requirements and extends this to all terminations. It also seeks to sharing identifiable information of parents. Again, this is in line with what I hear from you all the time around primacy of privacy in the state of New Hampshire. The department understands that and respects that as well, and we see that that is what's being crafted within this bill. However, I will just make a couple of notes. It does require date and place of the abortion performed. Per the federal HIPAA rules, date is considered an identifier. There's long HIPAA language around there, but date is considered an identifier. And so this tells us that we need to have a HIPAA compliant data system to collect the information. I would also suggest that the definition of place is unclear in the bill, and that's on line 8. This could be, left up to the department to understand. This could be an address, it could be a broader geographical location like a county, or it actually could just be the facility type. So if this bill were to move forward, I would think that we would need some further clarification around the intent of what a place is. Again, when you add the date and a place and then gestational age, which I'll speak to in a little bit, this is a place where you can start to constructively identify an individual perhaps in a small location. You would have the date of the procedure, you would know how far someone was along, and especially I would like to raise just a consideration for thought around those individuals that need to have a termination later in pregnancy, which is uncommon. So those events are much less common, and you add date and place, and that becomes a much smaller N. So you want to just take careful attention and make sure that we're collecting this data in the most secure and the most private way possible, if that's what the policymakers want to contemplate. Given the clinical considerations around termination that occur within the first trimester, we would also suggest at the department that you change gestational age into estimated gestational age. The first trimester, I am not a doctor, I'm neither a lawyer nor a doctor, so I would have, if you have detailed questions around this, but it's certainly my understanding that it would be much easier to comply with if that was an estimated gestational age, especially for that first trimester when things are moving along pretty quickly. Because of the sensitivity of these data requirements, so as I mentioned, the department is going to need to collect it in a secure data repository. So this would mean that we would have to develop a new HIPAA compliant electronic data system. And that system doesn't exist today. And so there would be a cost for developing such a system. We don't have it, we would have to build it. We have, and I appreciate in the recess that you suggested to add a fiscal note. I appreciate that. We've gone ahead and started some of that analysis, knowing that ultimately we probably would have a fiscal note attached to this bill. And so what we're seeing in similar systems that we have developed in the past couple of years, we would use a Salesforce platform, which you may have heard us talking about. It's what our DOIT, our Department of Information Technology, recommends. This is going to be within the shy of $1 million. It's $950,000 is our current estimate, and that's based on other systems that we have recently built that have sort of the same scale. Not the same information, but certainly the same scale with HIPAA compliant information. Additionally, we would want a little bit of extra, we would want to add on that a little extra money to be able to connect with the Office of Professional Licensure and Certification with OPLC so that we can do something called verification that the information coming in is from a real healthcare facility that's licensed with real providers. So we do that in other systems where we're gathering information. That's another one-time cost of about $250,000. Additionally, we probably need some people to take care of this data. And so we're suggesting that we would probably need to have at least one full-time person to manage the data and to do the statistical analyses, and then a part-time systems person who can do the troubleshooting on the sort of the IT side of the house. So those are the things that you would want to consider if you were thinking of moving this forward in order to effectuate it. And finally, the other note that I would just make from a technical perspective is the bill notes that it would be effective immediately. I think for all the reasons I've just described around getting a system up and running, understanding, working with facilities so they understand what their responsibility is that we would not be able to start this on day one. We would probably have to push that out for some time. So, in summary, data is data. We understand that other states use this data well. We certainly look to the estimates that are in other organizations that estimate the number of terminations in the state of New Hampshire. This would give us a more clear picture. But at the same time, I think as we've seen in past years, when we have tried as a policymaking entity to think about whether or not this is right for New Hampshire, we have always balanced the need for privacy and the resource allocation. Those are really the two things that we would suggest that we have had this conversation for many years. I think this bill gets closer in terms of the elements. I think there are some things that need to be fixed. But as the general court, we look to your guidance around balancing those two other issues of privacy and the resources. So thank you.
Questions? Senator Birdsall.
Thank you, Mr. Chair. Thank you for taking my questions. So we collect data on all types of medical procedures. And I know my husband is one of those pieces of data. What are collected on, what kind of data are collected on other procedures that we would have to change on this?
I'm not sure if I understand your question completely.
So we collect data on cancer.
Yes.
And the treatments of cancer, how many individuals in the state have cancer, and we have to apply the HIPAA rules on that as well.
Mm-hmm.
What is the difference?
That's a great question. Thank you, Senator Birdsall. So I'll use cancer, for example. We have authority for a cancer registry. And so we have a multi-million-dollar registry system where we collect that data and we collect that HIPAA compliant. So like this, it's possible. We can do that. We know how to collect that data securely in a way that protects people's privacy. It's simply the resources that are needed to be able to build that system. Currently, and this may also be part of what you're asking, we have ways to understand things like procedure codes that are collected through insurance, both Medicaid and commercial insurance. For these, for the terminations, it is unclear because the procedure codes may not necessarily show that this is a therapeutic abortion, that it may also, and I'll get a little graphic, it could look like a D&C. So as women, we know that there are times that you need to have that procedure. That surgical procedure might also be used for a termination of pregnancy. So we can't use that data to determine what that procedure was used for, which is why in order to collect this data correctly, we would need its own system.
Oh, yeah.
Thank you for that. So when you say you were given the authority for the data collection on the cancer and some of the other procedures, it was the legislature that gave you the authority?
Correct.
And it was the, follow-up?
Yes.
And it was the legislature that funded the capability of collecting that data?
Correct. Through either federal fund, in the case of cancer, we receive a good bit of federal funds. We also use a little bit of general funds.
Thank you.
Senator Prentice, I saw your hand up.
Just quickly, thank you, Chairman, and thank you, Associate Commissioner Tilly. I just want to clarify one thing and then ask a question. So clarification, we haven't refused, we just have not had the statutory authority.
Correct.
Okay, just being good about that. The second thing is that, and I heard, I think it was Representative Notter mention this, like county versus local. I think I just want to put the overall umbrella on aggregating the data is the best pathway in terms of protecting privacy, besides the provisions that, you've mentioned, you stated that have to do with HIPAA.
Correct. So we would also support reporting in aggregate levels, the public reporting. But for the data to be meaningful, we would need to have line level data reported to us. According to the data elements that are here, we would need to know the date and place, the age, the state, per procedure, so that we could actually do analysis. But what would be reported would be aggregate level data.
Senator Long.
Thank you, Mr. Chairman. Should that be in the legislation as far as what is publicly reported? Or?
It is certainly something to contemplate. It would create, bookends on what the department could report. I can tell you that the department already has its own data stewardship policies that we would, for example, not report a very small number in a town or a zip code. We couldn't do that from what's suggested here anyway, but in general, we have our own data stewardship policies that would prohibit us from presenting data that could be constructively identifiable.
Okay, great. Thank you, thank you.
Any other questions? I have a question. So looking back to where this is referring some OPLC involvement, would, having been over there for a while, and knowing what your mission is and what you're doing, would it make more sense than to put it completely under your umbrella and leave OPLC out of that? Because, you know, trying to talk to two systems and coordinate that, they're gonna have to write rules on it, I'm sure. Would it streamline the effort to put it all under DHHS?
That's certainly something to consider as you move forward. The reason it sits currently in OPLC because the way this is, it's directing that a provider must do something.
Sure.
And so typically directions to providers occur within OPLC. Collection of data typically lives within DHHS statutes. So this is a place, there's a role for each. And so that's something that you could consider with OLS and others to figure out where the right place is.
Okay. And just to understand the HIPAA requirements because we're getting down to the birth dates, we're getting down to admission date, that level of granularity in the data. If we were to change that and make it less granular, the reporting data, you know, date of age of birth or year of birth, month of procedure, I think the desire really is to get some idea what's going on out there. We heard the prime sponsor talking about that. Can we raise the level of granularity or reduce the level of granularity and be HIPAA compliant without having to and still get data that is achieving the goal of the bill?
So you would have to balance the degree to which you want to analyze the data, or you're seeking the department to analyze the data. I mean, you could feasibly just tell everyone once a year, give us on the back of a napkin how many procedures you had. That's all you would get. By this level of data as currently exists, we could actually provide some information that is meaningful. We would be able to look and tell you trends around age. We would be able to tell you trends around method. So there's some value in here if the goal is to understand the trends in the field.
Sure.
If you just want one number, you could do it in a way and just get one number, but that's not going to necessarily be particularly meaningful. And in my experience, legislators will then ask and say, well, can't you tell us something more about that? And we would not be able to tell you more than that.
Great, thank you. Any further questions? All right, thank you very much.
Thank you.
Courtney Tanner. I have two Courtneys here. So Courtney Tanner, you're up first.
Good morning.
Good morning.
For the record, Courtney Tanner, I serve as the Senior Director of Government Relations at Dartmouth Health. And we are proud to serve women across the state and our whole continuum of care for women who are in a reproductive age. We're home to our Northern New England Perinatal Quality Improvement Network, which is a consortium of solely focused on improving maternal health. And we also, on the other side of the spectrum, provide specialty obstetric services for women seeking reproductive health care and may need abortion services throughout different terms in their pregnancy, different stages. So we at Dartmouth Health appreciate that access to quality protected health information does drive health outcomes. Senator Bertzel, you talked a little bit about our cancer registry. We're proud to participate in the state's cancer registry. We're also proud to participate in our vaccine registry, grateful for that information that we're able to input and have to protect young and old lives across the Granite State. We also appreciate that we need to balance the rights of our patients' privacy, our provider safety, and ensuring access to quality care at the right time for our patients. We know that a number of other states do have abortion collection systems. However, we have a couple of considerations, and I won't repeat all that Trish Tilley said, but I just want to flag a couple that we at Dartmouth Health have some concerns about. So first is privacy of our patients. We have to take into consideration as we work on the bill, and Senator Aver, I'm so glad that you're willing to continue to work on this bill. We hope to be invited to the table to continue that work because we have to take into consideration how small our state really is. The volume of abortions that we're providing here in New Hampshire is extremely small, particularly up at our medical center. We have patients that are crossing the border from Vermont and New Hampshire. So the number of New Hampshire patients that are receiving abortion services, particularly in the later stages of their pregnancy, is extremely small. So very concerned about privacy. When we look at the bill as introduced, and I know there's a lot of work to be done to it, but I'm concerned when we take information like the date of an abortion is performed, the age of a patient, and the gestational age, even if it is estimated, that information could quickly be used to pinpoint a person, and really concerned about the privacy of our patients. One thing that Commissioner Tilley did not mention was that, and this is my responsibility to drive this home a little bit more, I'm concerned about the privacy of and the safety of our providers. We at Dartmouth Health do have specialty obstetric services, and we have those providers, and we're grateful to have them, and want to make sure that that service is available to our Granite Staters that need later term abortion services. And part of that is making sure our providers feel safe to perform and provide practice. And so as we work on this, would want to think about how are we articulating location and ensuring that our providers are safe. I'm happy to take questions.
So what I'm hearing is that you would be comfortable with this if the patient and provider privacy issues were addressed.
We are very happy to work on this bill with the committee. I think there are a number of pieces, and Commissioner Tilley recognized the number of them. Our providers have some concerns about a number of them. One thing to drive home, particularly for those who are receiving later term abortions, gestational age between 18 to 23 weeks, that number is extremely small in New Hampshire. And
We have to take your word for it because there's no data reporting, right?
But we have the data,
Yeah.
and it's protected, and so we know the number that we're performing. I am telling you, it is extremely small in New Hampshire, and so as we think about the privacy concerns, that particular patient population is one that we're going to want to be really protective of, really
But if
thoughtful
we can
about.
hammer out those details and ensure that because
I think there's
like
room.
my colleague said earlier today, I mean, New Hampshire, if we do anything, we take our privacy seriously. So I think that, if we can do that with this situation, you'd be willing to.
We are
help us
willing
out
to
with
work
this.
on this with the committee. We also have a number of requests out to our external partners that are that work on abortion data across the nation, and so would be happy to bring those resources to that
I'm
work.
gonna
as
ask
well.
one more question because I've got the microphone here. So you talk about your partners. Obviously, states are doing this. and
46
they're
other
doing it-
states.
Yes, and our neighbors are doing it. So they're doing it in a way that's secure and, confidentiality of both the patients and providers are secured. And we're kind of in the minority of a state not doing it. So, I mean, again, I'm going to take you up on your offer there, and in that, if you've got partner facilities that are doing this and they're comfortable with the data, I think that's what we're hearing is that's the biggest concern. And we've got more speakers to hear from, but so far the privacy thing has been the biggest thing we've heard
We
about.
want to be a part of the work.
Great, thank you. Any further questions from my committee? All right, thank you very much. So let's go with Courtney Reed. We've got two Courtneys today. So Courtney Reed, you're up.
Thank you, Senator, for taking my testimony. I also go by Court for short.
Court for short.
If
All
that
right.
helps astray any confusion.
Sounds like a dad joke.
For the record, my name is Courtney Reed. I serve as policy advocate with the ACLU of New Hampshire, and I'll be speaking in opposition to SB 36, primarily to just echo some of the privacy concerns we've heard from prior speakers. This is not the first time that the ACLU has opposed a data abortion collection bill, and when it has come through the legislature many times in the past, it has been has gone down because of these privacy risks. So not to repeat some of the concerns from previous speakers, but more to speak to incidences in this across the country, we're seeing the risk, of course, of data breaches in New Hampshire. In fact, in 2016, DHHS experienced a data breach affecting up to 15,000 individuals. That included identifiable information like social security numbers, addresses, or Medicaid numbers. But with New Hampshire being a rural state, even anonymized healthcare data has the risk of being re-identified. And despite these risks, there is definitely a lack of resource investment to ensure data security in SB 36. And more after Dobbs, the consequences of breaches of personal abortion data have become more significant, and the stakes have been really high for patients and providers, not just from a privacy standpoint, but from a criminalization standpoint, because we're seeing attorneys generals in states very hostile to abortion actually seek after personal identification data for criminal proceedings. And that includes charges for criminal conspiracy of doctors or for patients traveling out of states as they try to impose their abortion laws into states where patients are legally seeking care. So that is really at the top of concern for us because there is a lack of clarity about what data would be forward-facing to the public. And there's also no right to know exemption within this bill, which I think is really important for protecting patient information. With that, one of the specific provisions of the bill that is at the top of our concern is the patient's date of residence and the lack of clarity about the frequency of incident reports, especially if this data is stored in a manner that exposes patients' identity risks. So I just want to underscore that, of course, we know Granite Staters care a lot about privacy, and that's why the state passed with overwhelming support its own privacy amendment to the state constitution. And so we ask that the committee also put privacy at the top of mind when considering this bill, but ultimately there are a slate of concerns. So we would ask the committee an expedient to legislate, and I'm happy to take questions or have a follow-up conversation afterwards, as it seems like the bill is still a work in progress at the time.
Any questions? Great, thank you very much.
Thank you.
Liz Canada. All right. You knew I was going to call on you. You're up, ready to go.
Already. Good morning, honorable
Good morning.
members of the Senate Health and Human Services Committee. So happy to be here. My name's Liz Canada. I'm the, you know what, let me take this off in case that's easier for you to hear me. I'm the Advocacy Director at Planned Parenthood of Northern New England and Planned Parenthood New Hampshire Action Fund. We don't have a position on this bill right now. We have some background information and some concerns. Some have already been mentioned. Want to just first thank Senator Avard for mentioning that there's going to be some work done on this bill and that you're firmly committed to the privacy of data. So thank you for that, because that's one of the concerns, and I think you've heard it from other folks too. Some clarification about PP&E, because I think, Mr. Chairman, you brought up the 46 states, Maine and Vermont. So PP&E has health centers in Maine, New Hampshire, and Vermont. And our colleagues who are in Maine and Vermont submit the data to their state. They follow those applicable laws because PP&E will always follow the laws of the state. So in whatever version comes out, PPND will, of course, follow those laws. Because we know that good data means good public health outcomes, and that's what we all want. That's what we're all looking for. So some of the concerns, and I sent my testimony in a little bit late last night, but also just handed it out to you. So sort of 5 suggestions that we're offering, and I think you heard this earlier too from folks, a big thing being about aggregate data. So some of the pieces are around location, for example. So the specific location right now could be a concern for privacy. One suggestion is to change it to county. I think, when I've seen state level data from other, not just HHS, but from other departments, we've seen it broken down by county as well. So that could be one way to ensure privacy in that way. We've heard about the specific date, maybe changing that to month instead of date and just specifying that. Age range, our colleagues in Maine, for example, and you can see that data directly online, right? Like you can go online and see that. Colleagues in Maine have it based on sort of a range, preset range to offer that for the age of the patient. And then I think the other one under sort of this aggregate sort of category is around estimated gestational duration. The CDC has a prescribed list as well, might be something to model after, for example. So that's sort of number one, is like the aggregate data is incredibly important for the privacy of patients and providers. And we know, I know no matter where you stand on the topic of abortion, we all want patients and providers to be safe, and threats of violence are unacceptable. So that's number one. Number two being in-state versus out-of-state. Again, I think we just heard from Courtney Tanner about the numbers are really small, and patients who are coming here from other states, especially from states that are hostile to abortion, they could be at risk. We don't have a shield law here. Maine, Vermont, and Massachusetts all have shield laws to protect providers from other states sort of reaching in, and we're seeing other states passing those types of laws. So again, this is about protecting healthcare providers here and protecting patients if they are traveling here. Third one is about frequency of the data submission. So the suggestion would be to maybe put 1 or 2 dates directly in the bill and say, June 30th, December 31st, that's when the data collection will happen. That way the public knows when to expect this information, healthcare providers know, and lawmakers know. This is the information you want, and so you'll know when you're going to receive it on a regular basis, year after year. The other one, and I think we heard this earlier in maybe the opening testimony, is about the individualized medications. That's individualized healthcare. Probably it's not going to get you what you're sort of looking for in this, so we would recommend removing that. It's truly like patient-to-patient basis, and so that would be very individualized. And it's not a vital statistic, so that would be something that I think you're capturing when you ask about whether it's medication abortion or procedural abortion, so that would be something to remove. And then the other part, and I heard the department mention this, the reports being aggregated. I think it could be helpful to specify that in the bill, that it will be an aggregate report that comes out of the department. And all of these things, these are suggestions, there's probably more, but I wanted to highlight some of these pieces because, again, PP&E believes in good public health outcomes. That's what they strive for in the health centers, and comply with all state laws and all federal laws. And PP&E actually already voluntarily offers data to the Guttmacher Institute. So I put that link, I know paper copy doesn't have a link, but in your emails, you'll have that link so you can see the numbers right now. Like that's something that PP&E voluntarily sends into the Guttmacher Institute. I believe the other healthcare providers, the other abortion providers in the state do the same thing, but I don't speak for them because they collect it in the aggregate, and the providers don't need to worry about that sort of data breach or those concerns that exist in this bill as it currently is written. So I want to truly offer my help as you work on this bill. Happy to be available and work on this as needed to be supportive in that. So let me know how I can be helpful for you. But thank you for hearing my testimony. Happy to answer questions.
Great, thank you. Any questions? Senator Long, yes.
Thank you, Mr. Chairman. Thank you for your testimony. Now, the information required in the other states that those areas are reporting to, do they differ greatly from A to F, what we're requiring?
Yeah, let me get the, hold on a second. All right, here we go. So, yes, so like the specific date, like as we heard from the department, like those are identifiable, right? Like it would need to be a HIPAA compliant system. Maine has that. Maine has this online portal that the providers submit information into because it is a HIPAA compliant system. They have like a state level CDC in Maine. So they have those resources available. So I think what you probably heard from the department is that resources would need to be available to build this type of system. So it is different in that way.
Follow up, if I may?
Yes.
Thank you. So it's, so you're not, I mean, this one requires written. I don't know if that could be identified as filling out a form online.
Right.
But Maine has a portal where you just go in there and fill out their requirements.
Yep.
Okay, great. Thank you.
Sure thing. Of course. Thanks for the
Senator
question.
Bertzel. Oh, did you?
No, take Senator Britzel first. Then I'll go.
I'll give it up for a minute.
No, I'm going to yield to my colleague.
So I know we've talked about Maine and their portal, and I'm presuming that any type of information that we are going to be collecting will have a HIPAA compliant portal. But in the state of Massachusetts, and I'm presuming, I don't know if you know anything about Massachusetts, and I'm presuming they have a HIPAA portal.
PPNNE doesn't have health center. We're in Maine, New Hampshire, Vermont, so I'm not super familiar with Massachusetts. I apologize.
Okay, because
I can't speak to
looking at the Massachusetts law,
Mhm.
their requirements say date and place of the abortions performed, ages of the pregnant patients, method used to perform the abortions, the gestational age when the abortions were performed. So I'm presuming they do have HIPAA compliant for this information.
That would be my assumption as well. If they're collecting that information in that way, as we heard from the department, it's required to have HIPAA compliance for privacy in that way.
Okay, thank you.
But I can't speak to it. You know what?
I get it.
Okay, great.
You are on record.
I'm
but you're
on
not
record, so I do want to be clear. Yes, thank you.
Senator Prentice.
Thank you, Chair, and thank you, Liz, for really, it's less of a question and more of a clarification. I know I keep circling back to some specific themes here because I think that it's important for not just the committee, but for everybody. So right in the opening line, as I pick up your late night writings, preparing for today, it says when data are collected and secured safely, privately, and in the aggregate, PPNNE is not opposed to the practices. I know you're not taking a position on this bill, but you're emphasizing just the way in which it is collected, it is stored, and it is reported.
Exactly.
I think that, again, going back to how we do our business in New Hampshire.
Exactly.
And then, also having good health policy, there's a way to sync these two things.
Absolutely. Right. So as it's currently written, there are the concerns that I just laid out, but it sounds like Senator Avard is planning to work on it. And so again, offering the services to work on that in tandem to make sure that those things are all being met. Of course.
Any further questions? Very good. Thank you for coming in.
Thank you.
Bob Dunn. Bob Dunn here, yes.
Yes, good morning, Mr. Chair. I don't need to testify. I've got written testimony. I'd just be repeating what Senator Avard said essentially, so.
Great, we'll take
I'll
it.
that today.
Yes, yeah.
You'll hear from me on other things. In the
All right, thank you.
Thanks, Bob.
Ian Hewitt.
Thank you, Mr. Chair. Members of the committee, Ian Hewitt, appearing for Cornerstone.
I don't think your microphone's on. Oh, there you go.
Now you have to say it all over again.
Red is on.
There you go.
Only place where red means go.
That's right. Thank you, Mr. Chair, members of the committee, Ian Hewitt, counsel for Cornerstone. Abortion statistics are not a key priority for us this year, so we won't necessarily have a position on every aspect of this bill. But I did want to highlight two critical changes without which the bill would actually do more harm than good, and then we would oppose it. But the committee, I think, could easily make those changes, and it sounds like Senator Avard is on the same page. One is the definition of abortion used in this law. Currently, it uses a definition in 32943. That definition of abortion incorporates a definition of fetus in that subdivision that is currently extremely narrow. And the result would be that right now this bill would actually require only a few abortions at most per year be reported. So we would suggest changing that definition to cite instead the definition of abortion in RSA 132:32, which is just kind of a more colloquial, broader definition of abortion. The second, and really our main criteria for any statistics bill, is currently this bill does not have any penalties. And passing an abortion statistics bill with no or inadequate penalties would mean that abortion providers would be free to manufacture whatever statistics they wanted to publish and have them published as formal DHHS statistics, which would be worse than the status quo, where there are no formal abortion statistics published from a truthfulness and accuracy standpoint. And the last few years have shown pretty conclusively that if you legislate on really any polarizing issue like abortion and there are no or inadequate penalties, then the law is essentially openly ignored. And I'll give one recent pertinent example. The 2022 Patients' Bill of Rights prohibited, among other things, discrimination and medical treatment based on COVID vaccination status. The stiffest penalties that are in that law are under 151.16, a violation for a first offense, which is kind of similar to a traffic ticket, and a maximum fine of $2,000 by DHHS. Now, those penalties are in the law and seem to have really not deterred anyone from doing anything. And Dartmouth currently openly discriminates in organ transplants for organs other than kidneys based on COVID vaccination status. So since those penalties I just listed are obviously insufficient to have a deterrent effect, and since Dartmouth, as you just heard, is an abortion provider, we would suggest that the penalties here be at least for an intentional and knowing non-report, a Class A misdemeanor with a $10,000 fine per non-report. And although we don't currently have a position, I would be happy to take any questions, and I would also be happy to help the committee in preparing any event.
Any questions? No, thank you very much.
Thank you, Mr. Chair.
Okay, is there anyone else that would like to speak on Senate Bill 36? Yes. Come on up if you can state your name for the record.
Thank you, Mr. Chair. My name is Jason Hennessy. I'm from New Hampshire Right to Life, and I'm here to testify in favor of SB 36. New Hampshire Right to Life is the largest pro-life organization that is dedicated to that issue. Personally, I've also had some experience in areas related to this. I played a leadership role as part of a national NIH-funded study that focused on children from preconception up till age 21. And as part of that role, I oversaw the compliance of medical data and other collection with federal privacy rules. As a researcher, I've also published novel research in privacy in international peer-reviewed forums, and I hold a PhD in computational sciences and statistics. So my testimony today is going to be in three areas. First one is the need for statistics. Second one is the privacy aspects. And the third one is suggestions. So as you heard earlier, the fact is in New Hampshire, the only people who have the data are the providers themselves right now. They release it presumably when it meets their interests. And you can understand why they would do that. The legislature, so first off, I think the legislature and the public needs this data for a few reasons. And I'm just going to actually quote from the CDC. Well, my paraphrasing of their reasons. So in their last report from 22, they called out New Hampshire 22 times for the need for this data. The first reason that they cite is how effective contraception programs are. And so we cover contraception in various public programs. And right now we have no idea how effective it is because we have no idea what the number of pregnancies are. Second, we need a measure for the safety of abortion. Right now, there's no denominator, which is the total number of pregnancies by which you can measure. And so public health requires having that information. Finally, the CDC says that there's no estimate for the total number of pregnancies, and that's a vital public health requirement. Finally, I mean, from our organization's perspective, science and most major religions agree that during pregnancy, there is a distinct human life. And we record other vital statistics like births and deaths. And so we believe that it's worth recording these children in some way. So next, I want to talk about the privacy aspect. So as a privacy advocate myself, I commend the bill's explicit protections, not requiring personally identifiable information. You'll notice that there are no names. They're not even zip codes. From what I looked at the bill, it just requires a state. It's very common for governments to collect this type of information, and then they only release reports on the aggregates. So we already have examples of this, like NHCIS and adverse events reporting. And I'll also note that Maine and the two I checked out today, Maine, Vermont, and Massachusetts all collect very similar data to what's being proposed in this bill. And I will note that, at least in my hearing of the testimony, there was not one example of any harm that has come from any state collecting statistics like this. Zero, as far as I could tell. And you would think with 46 states, there would be at least one example if there was going to be harm. Finally, the changes that we would support. The first one, I believe, was already mentioned earlier, would be to target a different section of Chapter 329, ideally inserting it into a new one, because there's been no testimony that that part of Section 329 has caused any issues. So that's one request we would have. Another one would be to include the reporting of post-abortion complications. We owe it to the public to monitor the safety and not just have that be in the hands of private organizations. Third, as Cornerstone mentioned, we support including a penalty. So that way we can actually have an enforceable law. Fourth, we would recommend that the bill would be tweaked to explicitly include language for the prescribing of an abortion. I'll note that about 60 to 70% of abortions in the United States are through abortion pills. And so any comprehensive bill would have to cover both that and surgical abortion. Cornerstone already made the recommendation to use Chapter 132 as the definition of abortion. We would also suggest including ectopic pregnancies just as a public health thing. That chapter currently explicitly exempts ectopic pregnancy. And that's my recommendations. And I would be happy to take any questions.
Great. Are there any questions? No, thank you very much.
Thank you, Mr. Chair.
Anyone else that would like to speak who hasn't had an opportunity to speak? Yes.
Good morning, and thank you for giving me this opportunity to speak. My name is Janelle Hall. I am the Executive Director of the Equality Health Center here in Concord, but I'm actually here to speak for my colleague Sandy Denoncourt from the Lovering Health Center, who wanted to be here today but had some car troubles. So thank you for giving me this time to share her testimony with you all. Lovering Health Center is an independent nonprofit health center with 45 years of experience providing abortion care here in New Hampshire. They are one of the reproductive health care facilities directly impacted by SB 36, and oppose SB 36 for important reasons. SB 36 requires reporting a patient's state of residence in an increasingly hostile legal environment with no shield law in place to protect New Hampshire providers. In the post-Roe national landscape and current New Hampshire landscape, the timing and structure of SB 36 pose a threat to both providers and patients. This data is being requested at the same time that multiple states with abortion bans are just beginning to exercise rights to pursue and/or prosecute across state lines. Without legal protections or a shield law in New Hampshire, the legislatures who proposed this bill cannot safely say that there is no path to identifying patients who obtain legal abortion care here in New Hampshire and may live in a hostile state. They also cannot say that there is no path to identifying and then criminalizing the providers of that care. This risk is unacceptable. SB 36 allows for significant subjectivity in the interpretation of vital language, potentially collecting details that pose a risk to patient privacy and clinic safety. Reporting each abortion as a unique event with exact dates and with place of the abortion, age of the patient, gestational age, could result in enough information to identify patients in smaller communities. It is unclear if place requires a physical address, a facility name, a town, or would some other general location indicator be sufficient? Would patients managing medication abortions at home be identifiable if we had to report their home as a place of the abortion? The details of the date and place combined with the method could be used to identify days that a clinic is likely to have more procedural abortion patients on site. We do not publicly share our procedural clinic dates as there is a very real potential for heightened threat to the clinic, its staff, and patients on those days. It is unclear what will meet the reporting requirements for gestational age or what type of detail may be needed to satisfy the method used to perform the abortion. While it may be assumed that the data elements in SB 36 are simple and are benign, the truth is that there are complexities on how each of these may be interpreted. Wherever possible, the exact reporting elements must be defined to understand the true risk to patient privacy. Absent any details about specific elements required, we cannot support SB 36. SB 36 defines no clear intent to positively impact public health. Absent more practical information about how collecting this data will positively impact the health of New Hampshire citizens. It is hard to justify why data reporting is essential now and with these specific reporting elements. Abortion data is not being hidden or made unavailable because of healthcare facilities unwilling to provide it. We simply must be confident that we understand the use of the data and how any collection or reporting will be managed to ensure patient privacy. The Lovering voluntarily reports abortion data to two national organizations, the Guttmacher Institute and the National Abortion Federation. Aggregate statewide data includes data reported by Lovering is available through Guttmacher and publicly available today. You can go on their website. Lovering shares a commitment with the Department of Health and Human Services to improving public health. Unfortunately, the defunding of our Title X family planning contract and contracts for all New Hampshire abortion providers over the past 3 years sends a clear message. It signals that this is not the time when we can expect abortion data or more detailed abortion data to have a collaborative impact on rebuilding and enhancing the successful family planning strategies that achieve the lowest teenage unintended pregnancy rate in the country and would naturally and effectively impact abortion rates. And in closing, requiring the collection and reporting of abortion data using SB 36 is an overreach with potential harmful impacts. And we ask that you vote SB 36 inexpedient to legislate. Thank you for letting me read her testimony, and I'm happy to answer any questions.
Thank you. Are there any questions?
Thank you.
All set, thank you. Anyone else that would like to speak who hasn't spoken yet? All right, with that, Senator Avar, would you have anything else you'd like to say as prime sponsor?
No.
You're good, all right. I'm gonna close the hearing on Senate Bill 36. So, okay. Yeah.
Oh, yeah, so I do, yeah. I'll take in everybody.
Senator Birdsell seconded it. So we're in executive session of Senate Bill 47. So we got a motion ought to pass. Do I have a second?
Second.
Do I have a second? All those in favor say aye. Oh, wait, no, you're right. We need a motion.
I move to amend the effective date to January 1st, 2026.
Second.
All right, so the
And make a
motion
committee amendment on
is
that.
a committee amendment to change the effective date to January 1, 2026.
So moved.
All right, all those in favor say aye.
Aye.
No opposed. So the motion now is, we have an amendment, a committee amendment, and the motion is ought to pass
Motion
As
to move
amended.
on.
as amended. So, any discussion? All right, let's do it. All those in favor?
Aye.
Aye. Opposed? No, so we've got
Consent?
consent.
Second.
Can we take a vote on that?
Mm-hmm.
All right, the move to consent. All those in favor say aye.
Aye.
And then we don't take it out, right? Because it's on consent or?
Somebody has to, I'll take it out.
So you want to take it out? Okay.
Yeah, just in case someone wants to pull it off.
Okay, that's, all right. So you're ready just in case that, but you normally wouldn't speak to it if it's on consent.
Normally, but if someone takes it off, then we read the blurb.
All right, got it.
Need a motion to move out?
Yes,
So moved.
so
out.
move. All right, all those in favor say aye.
Aye.
Aye.